Hello Dental XP, thank you for this great opportunity to share my cases on such an important forum. My name is Mihnea Cafadaru and I am specialized in implant dentistry and periodontics. I want to share with you an interesting clinical video case that we have made in our dental clinic in Arad, Romania. For this female patient, we are treating a gingival recession in the right maxilla. The main issue is the sensibility during and after brushing and, of course, the aesthetic concern. You can see that a part of the exposed tooth structure on the first premolar was covered with composite in a previous session, but the patient did not like the appearance and also the sensibility remained almost the same. We have decided to proceed to a gingival augmentation procedure for the teeth 1, 3, 1, 4 and 1, 5 using connective tissue graft from palatal side with a modified tunneling technique. Because the recession was covered with composite, we had to remove it all before we could proceed to the surgery. We also cleaned the surface with pumice. All these steps are made prior to the incision in order to have the reference point intact and not contaminating the surfaces. We can see that we have a Miller class 1 defect, and we can also see that the keratinized gingiva tissue is sufficient for a coronal advanced flap. But we have decided to add some connective tissue graft underneath because we lack in density of the gingiva. We have a medium to thin biotype, and if we just advance the flap coronally, we will have a recession back after some time because there is no volume underneath to sustain the gingival position. Because we have a class 1 Miller situation, this is a high predictable type of procedure, the tunneling technique. We will have a good response from the tissue, and if we manage to stay away from perforations, big perforations and tearing of the tissue, we will have an uneventful healing. You can see we have 2.5 to 3 millimeters of keratinized tissue apical to the gingival, to the recession. Let's proceed. So, after the anesthesia, as for all tunneling procedures, we start with a circular incision using a microblade. This blade is a great tool because it makes easier to cut through the sulcus. Usually we use a double-sided blade. This time we used a one-sided blade. You can see it's not that easy, but it's anyway a great tool. We try to stay inside the sulcus all the time. That's why we have to hydrate the tissue all the time in order to advance easily inside the sulcus. We will extend the incisions on the second premolar, on the canine, and as you will see, on the lateral incisor. Why we are gonna do that? Because I want to advance coronally the flap from the second premolar to the canine. If I want to advance the flap from the canine, I will have to elevate the papilla and that is the only way I can gain access from the lateral incisor. We have to use proper light source and proper magnification for this type of procedures. In this case we use loops, dental loops, and we use a head-mounted light. We also use a dental microscope in our practice. It is important in the area of the papillae to use a full thickness incision to the bone. We have to feel the bone with the tip of the blade. If we try to stay in split thickness, we have the risk of tearing and detaching the papilla, and that is a complication. We don't want that. So as you can see, I try to stay inside and cut to the bone. In the apical part, we go in split thickness. We cannot be sure of that, but we try to stay in split thickness flap. It is not an easy task to manage this tissue. As you can see the blade, you can see the blade through the tissue, so it's not that thick. It's not the thin biotype also, but I want to be sure that I will not have a recession back. The studies shows that if we follow the procedure precisely, like we do in most of our cases, and the healing is uneventful, we will have a recession stabilization for approximately 2 to 5 years. After that period of time, we will have to expect a slight modification. So this is the incision from the lateral incisor. We will not advance the flap on the lateral incisor, but we have to gain access to the papilla between the canine and the lateral. This type of microblade is used only to gain access, and we try to stay with this blade inside the attached tissue. We don't go further to the mucogingival junction because the risk of perforation is higher in that area. We also use a tunneling knife, you will see, because it has a nice curvature in order to avoid perforation in the canine area. The bone is not flat in that region, as we all know, so it is harder to maintain the contact with a straight blade. We also use spoon blades that are bendable, thanks to Otto Zur and his team. We have learned that we can use that type of blade. So we have the tunneling knife. We managed to have a small perforation because we went to the straight blade in that area, but it's not I'm not concerned of that perforation. And we, as you can see, we start to split thickness the flap with this tunneling knife. It has to be sharpened from time to time. We don't want to tear the tissue underneath, we want to cut it. We take some pictures this time. I did use this tunneling knife to elevate the papilla a bit. It's not the ideal instrument for doing that. We use the papilla elevators, which are not sharp, and the risk of tearing the papilla is lower. This time we have used only this instrument. I felt confident in my incisions, so we did the elevation is almost done. We have to mobilize the flap enough in order to have a proper place for seating the graft. I will want to mobilize the flap also because I want to advance it coronally, and I don't want to get necrosis by put it in tension. I have to cut a bit more because the papilla is not moving enough. As you can see, we are almost done. We are pleased with the result. We are undermining the papilla, but we are staying in contact with the bone. We are not worried about detaching the periosteum in that area. We managed to have a small tearing of the papilla between the premolars, but the papilla remained attached. We further undermine the area. As you can see, we have more than enough. We took some pictures. I am pleased with the result. You can see the pictures. The picture you can see the papilla is a bit traumatized in that area. Now for the harvesting, we have decided to move on the opposite area because the suture will interfere with this type of sutures that we use will interfere with the healing of the flap in the first quadrant. So we have decided to harvest from the opposite area. We have almost no bleeding. You can see this is the suture. This is the graft with the fatty part on the exterior part. That was a mistake. We had to be more careful when we have placed the graft. As you can see, we have the fatty part on the exterior, and this is a higher risk for infections, as some studies showed. We did have an uneventful healing, but as a general rule we try not to keep the fatty part, and if we keep it we have to insert it with the faced with on the donor, on the periosteum. We use in this case a 4-0 suture, and we secure the double with a standard in-out technique on both sides. We want to pull the graft inside without putting too much pressure on one side. We try. This needle was a bit too big. When we perform surgeries and we record it, we try to see what we have done good and what we have done bad in order to avoid further mistakes. We try not to suction the graft. Okay. We always go back behind the papilla with the back of the needle, not with the tip, because otherwise we can get stuck and this case was easy. You can see the importance of undermining the tissue enough. You can see how easy it was to insert the graft if we use the proper technique. I don't want to keep the graft exposed for more than 1 millimeter in order to avoid necrosis. Sorry. We have used for the coronal advancement and for pressure, we have used the double sling knot with 5/0. We use composite between the teeth without etching and bonding. The perforation remained unsutured. We didn't need to do that. You can see the fatty part. That was not our best choice. Now we are gonna try to coronally advance the flap even more, and we will use a suture attached to the facial aspect of the canine and the premolar. You will see that we use etching and bonding and some flowable. The original idea was with brackets attached to the tooth. This is an easier procedure. It's handy. We have to be very careful with the manipulation of the tissue. We use a sharp needle, a new needle, with 6/0, sorry. We will use the bonding, which is auto-demineralizing. We don't want to have a big strong bond. We just want to stay there for 2 weeks. We will cure it, and we use some flowable, and after twisting the suture material with a gentle pull, we will stabilize it where we want. We can use a vertical direction, we can use oblique direction. We cure it and it will stay in place. After that we cut it. We will do the same on the first premolar, sorry. As you can see, we have not pull the flap too much, but we will have, as you will see in the end, a big compensation. We will expect a bigger volume than we need, but the situation will stabilize furthermore in the next months. I will only show you the clinical steps without the follow-up at 6 months, 3 and 6 months. I will only show you the picture that we have made at 2 weeks healing. The aim of this recording is only for the surgical part, but we will try to keep you posted on the forum with the further healing. The flow ball again. This is the final picture. As you can see, we have a big compensation of the flap. We didn't pull it too much, but we will expect a high volume in this area. And I will show you the situation at 2 weeks. We have a lot of tissue in this area. As you can see, in order to coronally advance the flap, we need to undermine the whole area if we want to have the papilla mobilization also. We have an uneventful healing. We will expect a drawback of the tissue, and we hope that we will have the gingival zenith in a few months at where we want it to be. Thank you very much for your attention. Thank you, Dental XP. This was an honor to show you my case. Have a good day.